Good morning. This is Dr. Joe Where's Becky, and I am your host on the forum today. Your normal host, Pat Sacco, is out, and so I'm one of the regular guests. And you get me today. And again, I am a local orthopedic specialist in the area. I work for Florida Orthopedic Specialists, and we have a couple offices here in Martin County, Port St. Lucie County. And in just a few minutes, I'm going to be joined by another orthopedic specialist, Dr. Paul Johnson, who is a foot and ankle specialist. Actually, let's call him a leg specialist. Everything from your hip, knee, foot and ankle. And we're going to be talking some general medical health, some orthopedic issues that are a bit more high yield that people tend to want to know about and ask more questions about. So just a little bit about me to get started for those who haven't heard me before, met me before. I do this show fairly regularly with Pat. It's the first Thursday of every month that I'm on the forum with Pat. And then I also do other radio shows. Every Wednesday morning, I do a show called Bone Talk with another of my partners called Dr. Sellers. And that's on WPSL 1590. But yep, today we got the forum. So a little bit about me, my background. I am a non-surgical orthopedic specialist. And that's a little bit odd to people because most people think, well, orthopedics, you're all surgeons, right? Well, I'm not. I am a specialist of the bracing, the physical therapy, the medications, and what's really best for you given your past medical history, what medicines you're on. I'm a specialist with the injections. And so a lot of people understand my specialty as interventional pain. I do a lot of cortisone injections, a lot of those gel injections and stem cell injections. And another common thing that people ask about me is, well, are you an MD? And yes, I am. I went to medical school at the University of Kansas, but I'm a Floridian at heart. And so after medical school, I came down here at Florida and did my general medicine training with the Gators in Gainesville. And then I did my fellowship in non-surgical orthopedics in Tampa. And I've been in this area about 8 years now with Dr. Powers and Dr. Forrester and Dr. Johnson with Florida Orthopedic Specialists. And again, we have the two offices in the area. One is kind of our main office that we've had for a long time in Port St. Lucie off of Highway 1 and Walton Road, that intersection right by that Dollar General. And then we have our newer office in Stuart, which is right by Willoughby Golf Course. It's off of Highway 1 and Indian Street. It's just a little bit west of that intersection. We're not the office on the Monterey Triangle. We're a different orthopedic office there. We're commonly confused. But anyways, if you're looking to find me, you can search on the internet for drw.org. And that's all spelled out, DOCTORW.org, drw.org. Or you can give us a call at our office. The telephone number there is 335-4770, 335-4770. And again, my guest who's going to be calling in a few minutes is Dr. Paul Johnson. Dr. Paul Johnson has quite the resume, being trained at it was Cornell. I believe it's Cornell was his undergraduate training. And then after that, he was trained by the Navy and was a longtime Navy surgeon, foot, ankle, leg, hip trauma surgeon, but was also their surgeon for replacements, hip replacements, knee replacements, clean out type procedures, foot and ankle clean outs, things like those bunions that people want to get corrected, or foot fractures, or chronic ankle injury issues needing reconstruction. That's really his specialty. And he's been in the area now about 5 years doing private practice. He completed his time in the service, and now he's been in private practice, enjoying that much calmer time with his family. So again, that'll be Paul Johnson in a few minutes. So real quick, I just want to talk about some things for a lot of people ask in lectures that I give. And one of the first things that people like to ask is, when do I consider going to the doctor? Sometimes when I see someone with a more minor complaint, I'm asking them, well, what brought you in here? And a lot of the time they're saying, well, my wife made me come in. So let me give you some common things for when someone should highly consider going to the doctor, to the orthopedic doctor. So the first thing is if your pain is severe, if your pain is miserable, it is bad, you can't live with this, you injured your ankle or your knee is just that bad, yes, come to the doctor for severe pain, please. It goes without saying. The next thing is if you're having regular issues with, your knee or your ankle, with whatever joint, and it's holding you back, it is not improving. Not improving pain that's really impacting you, impacting your quality of life, that's a sign that you should come and get this checked out. That random pain here and there, that's not really an issue that you necessarily have to come to the doctor for. That one time you got the zing in your arm, or that one day of a bothersome knee pain. We don't worry as much about those. It's the regular things that happen fairly often in a joint. Yeah, I highly consider coming to the doctor then. Now, how about if a pain is progressively getting worse? You got this mild knee ache that you're dealing with for some time, but as time goes on, it's not getting better, but it's only getting worse. That's also a sign. Come to the doctor. Maybe you injured your ankle. At first, it wasn't bad. A few days later, it's getting worse. A few days later, it's still getting worse. Yeah, you should be coming in for that. The next one is if pain is making you limp. We don't like limping. We don't like falling. And so if you're limping, if people are telling you that you're limping, and it's from something like a knee pain, well, you should be coming in. Almost falling is an issue. We see a lot of falls and we deal with a lot of issues because of falls. And so preventative management is key. There's that whole saying, let me see if I can get it right, an ounce of prevention is worth a pound of cure. And limping and falling are leading to bigger things, and we don't want to deal with those. The next thing is if you're having long-time pain in a joint, and let's put it this way, you're having long-time pain in a joint, it bothers you, you're complaining about it regularly, but you don't have a real treatment plan. That's another reason. I think it's kind of redundant given the other explanations I just gave. But if you don't really have a reason for why your ankle continues to hurt once you sprained it, several months ago, several years ago, and you just keep pounding anti-inflammatory pills or occasionally icing it. If it's a chronic thing and you don't understand why you're still having that pain, you should be coming in. I kind of just mentioned it right there. But if this is a pain that you're regularly taking anti-inflammatory pills for, and you don't know why you're taking that pain, you think it's arthritis, or you think maybe it's a tendon or a ligament, and you're not sure. We don't want people taking regular amount of anti-inflammatory pills unless that is the preferred option for that. Maybe you're limping around for many weeks or months and you're just taking those anti-inflammatory pills and you actually tore your Achilles tendon or you tore your ACL. Well, we don't want you taking all those medicines. That's not the ideal treatment for injuries like an ACL tear or an Achilles tear. Or maybe you're taking a lot of these medications for something like arthritis in your hip joint, but the best treatment for that would actually be to get a cortisone shot in that joint. And that would be much less of a risky option. All right, and perfect timing there as I'm finishing up with that subject. We got my partner, Dr. Paul Johnson, joining me this morning. Dr. Johnson, you there?
I am. Good morning.
Good morning. How you doing?
I'm hanging in. How about yourself?
Doing very good, thanks. Well, I just got done introducing our practice and giving our telephone number and our website and telling the audience about your background. And again, for those people who are looking to find us in the area, our telephone number is 335-4770. And again, I have my partner, Dr. Paul Johnson, who is, I guess I've kind of been describing you as a lower extremity specialist. Everything from the hip to the toes is kind of your specialty, right?
You got it. That's right. Yeah, it's been a great place to kind of focus efforts. A lot of kind of similar, but certainly interrelated conditions. So it's been a very rewarding practice for sure.
Yeah. Um, well, what's new? I just got done, after finishing, telling everyone about, our practice. I was just talking about some reasons, when people should really go to the doctor. That's kind of a question I get asked about a lot. I don't know, anything on your mind? What do you want to talk about this morning?
I actually, it's a great question. I just actually kind of come up fairly recently, and I was hoping to pick your brain a little bit, but it's a little bit of a niche thing. But I was so that anterior knee pain, especially in that young and usually female athlete, can kind of
Oh,
be a
yeah.
real bugaboo sometimes. What's your approach in terms of looking at that, working it up, treatment, all that good stuff?
Yeah, and that's good that you brought that up because I was talking about the older individual and reasons when to come in versus not, and the younger people. The problem I tend to see is that they suck up the pain so
Oh,
much
sure.
and they push through the pain, thinking it's okay, I'm young, I'm tough, I'm invincible, and
Sure.
uh, and then well, most often one of two things happen. One is that the pain gets so severe and terrible that it takes that much longer for the body to heal it and for us doing our right things for them to heal and get back to play. Instead of it taking a week or two, it takes them 6 or 8 weeks. Or because they're favoring it, then they do something wrong and then they create a bigger problem. Maybe they
Right.
had like just a tendonitis in the knee that was getting bad, but then by favoring it, they tear their ACL.
Right.
So uh, I think that's kind of my roundabout way of saying that young kids with pain, especially severe pain, don't push through it. If it's just something mild, okay, but don't grin and bear it. Come in.
I couldn't agree with you more. I have definitely seen actually both of those scenarios you're describing, where like you say, and listen, I resemble this remark that when you're young, you're invincible. You're going to get through this, no big deal, nothing can stop you. And two, I think and this is not just young folks. I think a lot of us forget about this too. Is that the sort of long term effects can really kind of come back to visit upon you with a vengeance. Something that you have like you say, an injury or something that you kind of push through, and I don't know, maybe even sort of patch together, and you kind of do get through it. But then 20 years later, the bill comes due, and all of a sudden that untreated ankle sprain that's been sort of chronically unstable, and now you're dealing with ankle arthritis, not just an ankle sprain or something along those lines. So. And listen, you come in, it's an ache or a pain, or heaven forbid, a more severe pain, and we take a look at it with you. At least then we can kind of know this. Oh yeah, so this is something we can watch. This is not that serious. It's okay. That peace of mind, that reassurance. But then certainly we've at least nipped it in the bud if it is something that has that potential down the road in the near or long term to cause a much worse problem, or to take a lot longer, as you suggest, to get back into good shape again because we let it grow out of control.
Yeah, yeah, absolutely. And Dr. Johnson, you have some younger kids, so for the parents out there, is there a way? You don't want to be that parent that's always rushing into the doctor, with just a minor complaint by your kid. Kids complain of a lot of things. Is there, some kind of a constellation of warning signs that you'd say, maybe you're actually seeing the kid limp when you're not
Yeah.
looking, or is it, if they've been complaining about it with a certain degree or tone, or if you, as a parent, what would you say? When do you
It is
take the kid
tough, and,
in?
and I've actually kind of checked myself a couple of times because a little bit of information can be a real dangerous thing. So you look at your own child, you're like, oh my gosh, this is something horrible. And then you take a deep breath and you start looking exactly like you say, a little bit more clinically at it, and you can say, okay, well, this is kind of normal. Especially with my kids are fairly young, and so as they're hitting those growth spurts, that sort of night pain can really be there, and that can be a little alarming, especially for first time parents, and even not, if it's the first time the kids are describing that. Usually that's the sort of thing, however, that will be sort of limited generally to nighttime, will not limit them during the course of their activities during the day. And it's a relatively short-lived experience for the most part. I would say certainly within a week or two, those symptoms should be on the wane. And so those things, again, are usually pretty benign. I think the limp is a very good one to actually look out for. And so kids may not sort of deliberately slow themselves down, but they will alter what they're doing, the way that they're walking and the way that they're moving, to address pain. And so they may still be out there playing, but if they're running a little funny or if they're kind of favoring an extremity, I think that's definitely something to look for. And the other thing too is sort of a little bit, kind of further down the line, but certainly with, kids fall down. Gravity is not going away, and I am about as accident prone as anybody can be. And so certainly I'm no friend of gravity, but But the kid who falls usually bounces back up and does pretty well, and 99% of the time it's no big deal. Kids are very flexible. Their bones are almost more rubber than they are bone at times, and so they do pretty well. But if you're having a lot of point tenderness, a very focal area that's uncomfortable or painful for the kid, especially with a little bit of pressure on it, obviously anything like a deformity, that those things you might want to get checked out. And certainly those things are more a little bit concerning, potentially for things like fracture and so forth. And just knowing for certain is probably the right answer. Even then, it may not be a big deal. There's certainly any number of childhood type injuries that are pretty benign and that get treated with just some basic conservative treatment. But especially if there's any of those sort of warning signs, I think those are probably worth getting it looked at just to make sure it is one of those things that can be watched. It doesn't require a more aggressive course of care.
Yep. And as far as, when to rush someone into the emergency department, I mean, you mentioned deformity, no one wants to be rushing to the emergency department in the middle of the night, but yeah, if there's some kind of major deformity, then obviously get them into the emergency department right away. I see most people running into the emergency department, and unfortunately, they don't need to go to the emergency department if you really just have faith and be religious about those things that you should do. Get the person on crutches or get it splinted. Just a simple thing at home. Get it elevated and iced. Give them anti-inflammatory pills, and things should calm down. And then you come in and see us in the morning, and you don't need to stay up all night in the emergency department.
That's a great point, and I think you're right. Just kind of getting the right degree of kind of that first line care, sort of the ice, the elevation, and listen. Sometimes these things will even evaporate. Though the pain will go away with a little bit of TLC. But that also is, I think, a good proof of concept too. And if there's a significant issue and it hasn't resolved with the basics, and certainly getting yourself and hopefully the child a good night's sleep, will kind of put a new perspective on it in the morning. If it's still troublesome, then at your convenience, we can get you in and get you looked at and make sure everything's okay.
Yeah, and the body, and kids especially, it has this amazing ability to heal itself. And sometimes looks like a terrible injury, 12 hours later is a completely different story. And obviously that's a very reassuring sign.
So. Oh, absolutely. And nothing more humbling than watching your kids outpace you in terms of that healing. Nothing makes you feel quite as old, but it's absolutely right. They're almost lizard-like in their way to bounce back from some of these things, and a few hours can make a huge difference in terms of those things. And that again is more of a red flag. If they're not bouncing back, then there's something here that really needs to be looked at, and better safe than sorry. And as I say, worst case scenario is you come in and we get to give you good news and a peace of mind. I think that's also pretty powerful. But perhaps even more importantly is if there is a problem that has that potential to go unchecked or get worse with time if it's untreated, the sooner we get in on those types of issues, I think almost universally, the better the outcome will be.
Yeah. And actually, that's a good segue. One of the opposite I like to talk about is symptoms that you don't need to worry about, where you don't have to rush into the doctor. So if you have a little ankle injury and, you do all those things that you're supposed to, and you elevate and you ice it, maybe you couldn't even, walk at first, but it was, midnight. But then the next morning, after you did those things, everything is gone and completely back to normal. Well, then I say, you don't have to come in and see us. If everything feels normal, it doesn't matter how it looked the day before, as long as it's doing great now and it feels normal, you're putting good weight on it. Fantastic. No need to rush in.
Yeah, absolutely. And it's a great point. And a lot of times those ankle sprains in particular, it's tough to tell the difference between an ankle sprain and a fracture in the first, even few hours. They're both going to swell. They're both going to be painful. There's a real chance you won't be able to put weight on it. Again, if there's an obvious deformity, that's a different story. That's a lot more likely, of course, to be a fracture. But if you give it the time and, a little rest, elevation, ACE wrap, maybe keep the weight off it for a little bit, and things are calming down, that won't happen if it's a true fracture. They're going to remain painful, swollen, and difficult to put weight on. And so those things are key. That I will have one little brief caveat on though, and this is kind of a more of an anecdotal story, but these things happen, and that people will try to convince themselves that they're putting weight on the ankle and that they're doing fine, even if it's this horrible limp and this most awkward thing. My poor mother did something similar where, I'm getting a call from her on the phone. I'm sort of going through, well, can you put weight on it? She said, yeah, no, I can walk on it and all that. I'm like, okay, then you're probably okay. I go home to see her that evening, and her idea of walking on this thing was the most awkward and horrific thing I've ever seen. I'm like, Mom, you've broken your ankle. We got to get you in the hospital here. So, if it's normal walking, if it's normal weight bearing, if people aren't looking at you funny, that's probably a good sign that you're doing okay. If it's, it hurts and I'm agonizing pain and I'm kind of, half limping and, maybe you're not really walking on it, that might still be something worth getting looked at.
Oh, definitely. Yep. Yep. I've seen those too.
Yeah.
Yeah, another one that I tell people not to worry about, and I'm sure you see this one all the time too, is people coming in because of a noisy joint. Like my knee
Oh, yes.
clicks, it feels fine. You can do everything normal. There's no other symptoms at all, but maybe the knee makes a noise or my neck makes a noise. When I rotate, noisy joints by themselves, with no other symptoms, nothing to worry about. As long as
100%
it's
agree.
not having other symptoms with it. If you're having pain with that, if it's making you limp, of course, yeah, noisy joints. But noisy joints by themselves as an isolated symptom, nothing to worry about.
That's right. That's just what they do. And I think as a general rule, as you get older, they get louder and make more interesting noises. But at the same time, it's just a collection usually of some fluid shifting of the joint or those types of things, entirely benign. No pain, no swelling, no instability, any of those things, fair enough. We should probably take a look at it with you. But unfortunately, yeah, clicking, popping, noisy joints, that's just part of being a human being these days.
Yeah, yeah. And one thing that sometimes people come in for that's a little bit kind of questionable is a swollen joint. Maybe the knee, they feel like it has some extra swelling to it. And so for the most part, I tell people if it's just some swelling alone, the swelling is not worsening and it's just by itself. I tend to say that's not something to worry about or come into the doctor for. But then of course we kind of have to talk a little bit about DVTs, and that comes up commonly. But swollen joints by themselves, not worsening, are okay in my book.
I absolutely agree with you. And again, that can just be a little extra fluid. It can sometimes be a little bit of overuse, very mild, benign things. But if you're not having that pain or difficulty putting weight on the joint or moving the joint, it's just the swelling. I think that's much more on ice, elevation, some anti-inflammatory over-the-counter stuff. Those things will tend to get better pretty much on their own. Or, again, nothing that you need to worry about and rush in for, certainly keeping an eye on it. But you raise a good point, and certainly spontaneous DVT or those clots can happen, and even without an injury or a significant history, those things are sometimes a genetic component. They can definitely happen, but they're usually not going to just be swelling. It's going to be swelling with pain. Obviously, the pain is going to be pretty focal to where the veins are for the most part, so that tends to be the back half of the calf or the knee area. Sometimes the inner portion of the thigh, although that's a little bit less common. And folks who have a risk factor for those should also take it seriously. I might be a little bit, quicker on the trigger if you have a history of things like smoking, oral contraceptive pills, any history of malignancy. If you've had sort of prolonged immobilization, if you just got off that 5-hour flight, I think is the one everybody knows about. I suppose in this day and age, maybe that's a little less common, but certainly those are things to kind of increase the risk factors of that swelling being maybe a clot, and for the headache and time it would take to get the ultrasound to rule out that clot. I think it's well worth it to avoid the risk of an untreated deep vein thrombosis, that clot.
Yeah, and I see so many people coming in, with maybe thigh pain or just knee pain, and their legs look completely normal otherwise. It is extremely rare that would be a cause of a DVT, and the DVTs they do really tend to follow the book, but we also hear these crazy cases where a DVT kind of catches us by surprise. Have you ever I've never had one of those that's been a crazy abnormal presentation that surprised me, and a person has had a blood clot in their legs. Have you ever personally seen one, or any thoughts on some of those that they're a little bit more borderline, things to look out for?
It's tough. I would think maybe there was one that I can think of where it was one of these. Well, it doesn't really sort of. We'll get the DVT study and the ultrasound. We'll just double check, and it ended up being positive. But usually there is sort of the big hallmarks, and it kind of either looks and sort of smells and sniffs like one. In fact, I would say far more common is that it sort of looks like it's going to be a DVT. There's a good story. There's a good clinical exam. It's, it certainly looks like it might be a DVT. Let's get the study. And it comes back negative. And that's okay. I'd rather that than the other. But I certainly think that if, again, maybe some of those risk factors, if we're on the fence, it's probably worth double checking. And you do hear those occasional stories. And so if it really doesn't seem to be getting better, or if it really just kind of nags at you, I listen, I understand for peace of mind, sometimes that's the thing to do, is to get it looked at. And certainly, like I said, I'd rather err on the side of caution if we had to. I mean, DVTs can be, kind of annoying and sort of painful, but they can be serious. They can create significant, cardiac or pulmonary complications, even, the rare fatality. Certainly I think in those cases, yeah, I mean, ruling that out is important. But I think also as a peace of mind, the vast majority of people who were just, kind of asymptomatic will not have clots or not have any clot of significance. So I think for the most part, unless you've got some risk factors or a good story as to why it might be happening, or certainly those exam findings, the swelling, the pain, even some redness sometimes, I think the odds of it being a DVT are pretty remote.
Yeah, completely agree. And hey, Dr. Johnson, I'm just getting the signal here. We're going to take a couple-minute break for commercials, and then we'll be right back to talk more.
Talk to you then.
right, welcome back. I am Dr. Joe Wiersbecki, and I'm here with my partner, Dr. Paul Johnson, and we are talking general medical health and orthopedic health. And again, we are two of the doctors here in town in Port St. Lucie, Stewart area. Our telephone number is 335-4770 for Florida orthopedic specialists, 335-4770. And you can find Dr. Johnson and I fairly regularly the first Thursday of the month from 9 to 10 on this station. And you'll also find us and Dr. Sellers on Bone Talk every Wednesday from 9 to 10. No, 10 to 11 on 1590 WPSL. All right, Dr. Johnson. So we're back. Any topics you wanted to talk about next, or do you want me to throw one out there?
No, what you got? Go ahead. I'm engaged.
So I'm a little curious. You and I have never talked about partial knee replacements versus full knee replacements. And if you want to throw in, talking about, knee cleanouts and whatnot, a lot of people come in and ask me, all right, it's time for the surgery. Am I a candidate for a partial knee replacement? And I'm given a certain spiel. I guess what's your conversation like when someone asks you, can we do a partial knee replacement instead of the full knee replacement?
Sure, that's a great question. And I think a lot of it depends on sort of where the arthritis is in the knee. And so if you've got a knee that's sort of generally worn out, there is, maybe it's a bit worse in one spot than the other, but what we think of as the knee is one joint. We sort of break down into three separate compartments. And so there's sort of an inner half of the knee, an outer half of the knee, and then behind the kneecap. And that sometimes gets overlooked as well when people think about their knee. But there's really three different areas where a bone is meeting another bone. And so looking at those three areas, you really want to have just one involved in the arthritic process if you're going to do a partial. Traditionally, and sort of with general statistics, the most common is going to be that medial compartment, the inside half of the knee, is the one that seems to wear down for most people, and that's probably the most common type of partial that's done. Doing other partial knee replacements is a bit more challenging, and the history with them has been a little bit less tried and true. So there was for a while they were doing what's called a patellofemoral replacement. That's kind of the behind the kneecap stuff. And there have been some loosenings and some failures when you're doing that in isolation. The outer half of the knee, the lateral compartment, is increasingly being done now as a single compartment, but even that's relatively new. And so a lot of the workup leading up to am I a good candidate for partial knee replacement is looking in great detail at that knee. And there's a lot of different ways that can be accomplished. And so sometimes by the time that people are getting to the point where, listen, I'm kind of been doing the basics, I'm trying everything, I can't quite get over this, I need to do something more, am I a good candidate? They maybe have had a knee scope in the recent past, and someone's been in there maybe cleaning up a torn meniscus, and it turns out that the arthritis is a lot more advanced than maybe the imaging or the history might suggest. And they get a chance to really look at that knee sort of as close to in person as you can get. That camera is going to give you a direct ability to look at the other two compartments and gauge the severity of the arthritis there. And the reason that's important is if you're doing a partial knee replacement, you're relying on those other two parts of the knee to be in good shape that they can continue to maintain, and we're just fixing the bad thing. You don't throw out the whole car because you get one tire that's flat. You replace the flat tire and you can get going. But that assumes that everything else on the car is working, right? So if that's the case, then that's a good candidate usually for partial knee replacements. Now, the other factor is, okay, we've done your partial knee replacement, great, we got rid of the arthritis, you're doing wonderfully, is down the road. Are those other two compartments at risk for developing arthritis, and will they continue to behave themselves? Or are we going to be looking to convert that partial knee replacement into a total knee replacement to take care of those other areas of arthritis? And the reason that that's significant is it's sort of like, okay, well, I fixed the part that's broken now, we'll just fix the parts that are broken later if they break. Is that the surgery to do that is that much more challenging, and the risks associated with it do go up. And so if you're doing a partial knee replacement, you're at greater risk for what's called a revision surgery, needing more surgery down the road if the rest of the knee wears out. And now that surgery has some higher risks associated with it. Not sky high, not 100% doom and gloom, but certainly an increased risk of something happening. Some scar tissue will form. Maybe there's a hard time with the knee getting moving. Maybe there's an increased risk of infection. All of those things can and do happen. And so sometimes a total knee replacement is less likely potentially to need that revision down the road because you've addressed the whole knee and you've taken out all the sources of potential arthritis. But again, you look at the patient's age and their function, the sort of things that they want to get back to. And so the tendency, I think, is for someone who's a bit younger to need the partial replacement because they want to get back to more aggressive and active activities. The more of your knee that's sort of in there helping out with that, the better those things tend to go. On the other hand, they're also going to have a much longer time to spend with that knee. If you're 40, you have another 40, 50 years to live with that knee. And if you've got maybe a trauma that led to some bad arthritis, you get the partial, that arthritis is taken care of. Well, now you're 60 and you've had that partial for 20 years, and now, oh my gosh, the other parts of the knee are starting to wear down. We got to go back in and do this much bigger surgery. And so that's kind of that consideration. And it's a lot of times, I think it's an easier decision, and you've got sort of the extreme cases. If someone's 75 and, the other two compartments are kind of maybe okay, borderline, maybe a little beat up, but, the one side's really bad, maybe you just do the total and be done with it. And that takes care of the problem. You don't have to worry about it. It's a sort of one and done surgery. Or someone, like I say, who's 40, it's a little easier to say, well, listen, a total knee at your age, you're going to need revisions for a total knee. So the difference between doing the partial, okay, let's just do the partial, get you the rest of that knee as much life as it can. And if we have to and they wear down, then we'll worry about that total revision. But someone who's in between, maybe in their 50s or early 60s, who's got just fairly isolated arthritis, it's a little bit more of a question. And so I think it's important to kind of know the ups and downs of those two options. To try to make the best decision we can for that person's knee as an individual, and that's where it's definitely worth having that conversation. And again, if they haven't had at least a knee scope, then certainly an MRI, X-rays can be a little bit deceiving sometimes when it comes to these decisions. So having all the information we can to make that decision, I think, is key. The last thing you want to do is go in for a partial knee and realize that, whoops, there's some giant potholes in the cartilage that didn't show up on an X-ray, but we probably would have caught with an MRI. We probably should have checked that for, So that's why we were pretty aggressive about the workup leading up to that decision to make sure we're making the best possible decision.
Yeah, I like that. And I can really hear it in the way that you're talking. That's how we think. We're always thinking many steps ahead for you in the best way, that we can predict the future.
That's a great point,
and so
yeah.
I guess maybe what you could help me with here is, so as we think about, a knee clean out, a lot of the times people are sometimes starting with, there's not really anything that you have to revise after a clean out. But after a partial knee replacement, I guess maybe what's the approximate lifetime for a partial knee replacement? And then could you walk me through what's that surgery like to revise the partial knee replacement and turn it into a full knee replacement? And then maybe could you also talk about, if someone gets a total knee replacement at a really young age, what's that like to revise a total knee replacement? Can you walk us through that a little bit in ways I could understand? Because I'm not really
Absolutely.
sure. Yeah, what the patient goes through and what you're going through as the surgeon.
Well, that's it. It's a great question. So as far as the lifespan of partials, I think there's a fair amount of variability, and I think the reason is there's a lot of different patients who will have a partial knee replacement, and the lifespan of a partial knee replacement for someone who gets it, let's say, the earlier example, when they're 40, maybe they had a motor vehicle accident, an old sports injury that caught up with them. They're going to be much more aggressive in their use of that knee. Now, the good news is that the rest of the knee is there to help soak up the stress of those activities and probably helps to protect it. So it's certainly, we're looking at it, 15, 20 year, I think, for a lot of people. But if you're particularly aggressive, if you are engaging in a lot of high impact activities, then I would tend to at least counsel folks that the lifespan is going to be on the shorter end of things, and to anticipate that. Now, if the implant exceeds our expectations and is fine and stable and lasts much longer, fantastic. I'm not looking to do anything that needs to be done, and I'm happy to be disappointed in that particular respect. With total knees, we're pretty universally, I think, seeing a lifespan, again, of roughly, I think, 20 plus years now with some of the newer components and the newer technologies that are going into those components. In particular, the way that the plastic, the poly that goes in between the metal has been processed is really expanded the lifespan. And that was really the weak spot. That was the thing that was wearing down and causing problems. And with that wearing down much more slowly, the lifespan accordingly is much longer. There is still definitely a variability there, however. And again, that's some activity-based factors, To be frank, body weight certainly plays a role, and that makes sense. This is a machine. It's a mechanical component that's in your body, and the more aggressive and the harsher the conditions under which it's utilized, the more quickly it's expected to wear down. And so that's sort of the one caveat with all of these things, that there are factors that will definitely change the lifespan, at least the expected lifespan, and those things need to be kind of factored in. So, people who are very aggressive and very active will probably get more out of that replacement because they're going to be able to get back to those activities in a sense, but they're also going to be burning the candle that burns twice as bright, burns half as long type of thing. So it's going to wear out much more quickly. At least that's the theory. As far as revisions go, when you take a total knee, usually what you're revising is going to be the plastic. And so even though it does now last much longer, that is one of the things that is most likely in need of replacement. The other kind of revision is for when the metal starts to loosen from the bone. That's a much different process. So starting with the simpler one, the plastic basically is going to be the same incision that was used to put the knee in the first place. The surgery is usually much shorter because what we're essentially doing is sort of popping out the plastic. We take it out. We do clean things out while we're in there. We might as well take advantage of the opportunity. So if there's any scar tissue, we'll tend to clean that out a little bit. And there really is just a sort of a washing out factor. We've opened up the knee again. We want to reduce risks of infection. So we're going to do a little cleaning while we're in there and then putting the new plastic in. But it's, like I say, a much shorter surgery than the initial one. And recovery is much faster accordingly. We've done sort of less collateral damage. We're not having to take out portions of the bone and all of that. So while there is still the incision to heal and all of that, the early restrictions are much fewer, and people tend to bounce back much more quickly. We're looking at usually a 6-month recovery for a fresh total knee, a brand new total knee. Recovery process is probably somewhere between 2 to 3 months, I would think, for that kind of revision on average. And by which I mean back up and doing the same level of activity that you might expect at 6 months after your first knee. Not that there isn't some degree of healing and strengthening to go on, but it tends to be a much briefer period.
So you're saying that 2 to 3 months for popping out the plastic and putting the plastic back in, or are you talking about the revision?
For the revision portion of it, but that's again to get back to a high level of function. People are up and walking day one, the incision healing over the first couple of weeks, and then it just takes a little time to ramp up. I would say probably over the course of maybe 4 to 6 weeks, people are doing 85% of what they want to do, and then probably spending some time to build up some strength for any higher impact activity. So up and walking and taking the dog for a walk or doing some bicycling, those types of things happen fairly early on after that revision. Okay. Now, if you have to take all the metal and plastic out, that's a different story, and that's a much, much longer recovery.
Yeah, that's the feared revision.
Yeah, absolutely.
The surgery that no one wants to. And so what's the recovery like when you have to, when the metal's loosening from your standard knee replacement and you have to take everything out and put new metal in, new plastic in, do the full revision? What's that recovery life? Yeah, tell me about that.
Yeah, so I think you're looking probably at something that's a bit more comparable to the original knee replacement, and can in some cases, especially the more severe or the more complex revisions, if I can be a little vague, but if you're having to really work very hard to reimplant the new metal. So it sounds like, okay, well, the metal's loosening, you take out the old one, you just put a new one in, and you're fine. The reality is you have to kind of make brand new cuts in the bone. Usually you're going to have to use what's called a revision prosthesis. So a lot of our first line prostheses, the metal that actually goes in is fairly low profile. We're trying to save as much of your bone as we possibly can. So we're just taking out the edges of the bone to put this new metal in. And that generally works very well, and it's usually cemented into place. There are some exceptions to that, but I think still most commonly is that cemented, sort of like a dental cement almost. It helps to effectively glue the metal to the bone. And when you come out, you have to kind of clean up all those cuts again, and you're going to use what's usually called a stemmed or a revision prosthesis, where you're taking advantage of the fact that the bones have these hollow cores, the intramedullary canals, and those allow for some additional stability in these revision prostheses because by fact, we have to take away a little bit more of the bone. And that's one of the reasons we like to leave as much bone as we can in the first place in case there's that need for revision down the road. The more bone that you have left, the easier it is, heaven forbid, there's a trauma, an injury, need for revision, to be able to put a new prosthesis in or fix that problem. And so each successive major revision, you're gradually losing more and more of your native bone, and the way to get the new knee in becomes more and more complicated. And so those can be a bit longer to recover from. So certainly if you're doing much more resection or a lot of clean out or really working harder to get that stability back in place, That's, I think, the big rate limiting factor for folks when they come out of that surgery, to get the motion back, to build up the strength. All of those things are much closer, in some cases worse than the original surgery, simply because it's a much bigger surgery than that initial one generally would have been.
What's the surgery like converting a partial knee replacement to a full knee replacement? In comparison to just putting in a total knee, is that something fairly simple for you? And does the recovery change? If you compare a person who just got a total knee replacement compared to a person who is getting a partial knee replacement compared to a full knee replacement. I mean, is the surgery and the recoveries equal in those person?
I think the recoveries are probably comparable. There may be a little bit longer recovery if you're going through from a partial to a total than from your arthritic knee to a total, and there's certainly some outliers. So I don't want to make a too blanket a statement there. But if you have horrific arthritis and a bad deformity, and we're doing a total knee, that's still a pretty big recovery, and that might be one of the worst case scenarios. But the big issue with the partial to a total seems to be, number one, you have to get the partial out. And a lot of times you're not revising the partial because the partial has loosened or worn out. It may very well still be readily affixed to the bone, and you're having to kind of pry it free. And remember, we put these things in, we ideally never want them coming out. So you're kind of working against yourself in that sense. And so you're trying to get these to be removed. Once that's out, the rest of the surgery is fairly similar to your initial total knee, except that we have to kind of account for the fact that some of the bone that normally would still be there has been removed to put the partial in. And those are things that are more technical on our end, and that's something that we worry about. But as far as the recovery process, generally that's not going to impact it very much. What we're looking at is some additional collateral damage potentially from having to take all of this well-fixed metal out of the bone and then put the new one in. And so I wouldn't say it's hugely different than an initial total knee. I think the headache tends to come into play when we're looking at the rates of complications after these surgeries. And so that's that risk column of the risk-benefit equation when we're looking at these surgical decisions. And so the risks are always there, and we're doing everything humanly possible to keep them as close to zero as we can, but they're never truly zero. Well, those risks do creep up a bit if we're going from from a regular knee to a total knee versus revising a partial knee to a total knee. And those are on the basis of statistics. And so the big risks are going to be increased risk of loss of motion, so stiffness of the knee, infection are probably the two biggest, wound healing potentially, although that's a little bit less common. But when those risks start to creep up because there's been a prior surgery, because we are revising, those things do play a little bit of a role, usually for that initial decision, as we kind of talked about earlier. But it's just something for the patient to be aware of. And even at the point of having, well, listen, I've had a partial, it did great by me, but now the rest of the knee is catching up to that, first part of the knee that failed. It's starting to show the arthritis. Is it worth going through that process of revising to a total knee? Well, now you have to look at that risk column a little bit differently than you would have if it was just an arthritic knee to a total knee. We're going from that partial knee to a total knee. That's a little bit of an increased risk. Now, again, not sky high. You're not, flipping a coin to see if you're going to get through this safely. It's certainly, low increases. The numbers overall remain fairly low, but they're appreciably higher. And with that in mind, it's important to kind of weigh those risks as risk specific to the partial to total knee, not just from a native knee to a total knee.
Oh, that's interesting. I don't know this stuff because I'm not the surgeon. That's interesting to hear. Let me ask you. So you're talking about converting a partial knee to a full knee, the complications there compared to just a person's regular arthritis knee, to doing a knee replacement and the risk factors there. And you mentioned a lot of things that are really specific to kind of the knee itself. Do you see any kind of increased risk with general medicine things, any increased rates in those two groups, with things like blood clots, strokes, heart attacks, complications with anesthesia, comparing, just getting a new knee compared to a partial knee to a full knee?
I think in general, the one determinant would probably be the length of surgery. And so there are certainly a number of studies that have shown the longer that you're in the OR, and I don't think this comes as a great shock to anybody, but the longer you're in the OR, the greater the risk of there being a complication, specifically infections, but also, as you mentioned, things like cardiac function and clots are actually increased as well. And so there is certainly that potential, and there probably is an overall increased rate of time it takes to do the partial to convert a partial to a total than there is to do a native knee to a total knee, because you're having to take out all of that metal, and you have to now account for that lost bone when you're doing your calculations for your new total knee prosthesis. So, and so I think if you've got someone who does a lot of these revisions, and there's certainly an argument to be made that, as you get further and more complex with these types of surgeries, you really do want to go to someone who's fairly high volume, who's very specialized in that area, to try to minimize how much that additional time would be required, and all these other factors can be minimized to some degree with that. And so I think overall those are also increased, although I apologize, I don't know those numbers off the top of my head, but they are because of that extra time, because that complexity is increased, they're going to be a bit higher. Again, I think we're talking about marginal increases, but they're certainly going to be higher than the native knee under average circumstances. There are certainly, as I mentioned, folks with terrible arthritis who have really tried to push this off, and it's got a lot of deformity. And certainly even those basic, from arthritic knee to total knee surgeries are still time consuming and can take a little bit longer than your average knee would. So those are going to be more of the outliers that will muddy the waters a little bit from a statistic standpoint. But those are also knees that you can counsel someone individually and say, listen, your knee's a little bit further down the road than the average knee would be at this point. So, we're going to have to take into consideration these additional risks for you, for your knee, for that surgery. And that's where we're trying to, obviously medicine is unfortunately based on these large population studies. We're kind of looking at averages across the whole, population, but everyone's an individual, and where they may fall on a given spectrum is, sometimes predictable, sometimes hard to do. But if you can see some factors that put them towards that higher risk category based on who they are and their medical issues maybe, or the severity of their arthritis, you can at least counsel them on a more individual person-to-person level. You hate to talk to someone like they're just a statistic. That's not, I don't think it's why either one of us certainly got into medicine. You want to talk to people, not to stats,
Yeah, absolutely. Well, and I think it's a great kind of wrapping it up point. Yep, we're finishing our hour here. And so, Dr. Johnson, thank you so much for joining me again on the forum. This is fun as always. Yeah, we'll do it again. And for everyone else out there, a little bit about us in case you didn't catch it earlier in the show. Dr. Johnson and myself, so Dr. Paul Johnson, and I am Dr. Joe Wiersbecki. You'll find us at Florida Orthopedic Specialists. Again, we have 2 offices here in town, one in Port St. Lucie off of Highway 1 and Walton Road, and the other office in Stewart, close to Willoughby Golf Course. It's just a little bit west of the corner of Highway 1 and Indian Street. And our telephone number is 335-4770, and that'll connect you to either office, where you can either make an appointment to come in that same day or a future appointment. And again, that number is 335-4770 for Florida Orthopedic Specialists, or you can find us on the web. And my website is drw.org, all spelled out, doctorw.org. All right, thanks again. Have a great day.